That sounds good. Okay, thanks, Jason. Good to see Danita on here as well. So yeah, coming to you live from Treaty 6 territory today, usually from the Treaty 4 area down in Regina. But today we're going to be discussing peer mentor connections for recovery from addictions in First Nations communities and focusing on something called a two-eyed seeing approach. So yeah, let's jump right into it. So as an overview, we'll discuss a bit of a patient case and kind of where the genesis of this, the connection of our program in working with peers, where that all comes from. There's quite a bit of different terminology in here, so just to get us all on the same page, we'll discuss a bit of some of these terms when it comes to addiction and recovery. We're also going to look at different treatment gaps for recovery from addiction or substance use disorder. And then how do we connect peers to care? So what that process looks like, what the rationale is, and then getting into perhaps what training and certification would look like for our peers. So we're working together with the Wellness Wheel right now to develop training and certification. That's kind of where we currently are now. And the next steps for us is the deployment of peers into the healthcare system and looking at what that'll look like. So for the patient case, and this is quite a standard normal case that Danita and I see a lot of. So in this scenario, we're working as a hospital pharmacist, on a medical unit. And we have a patient who's come up from the emergency and they're diagnosed with sepsis. And you're asked as part of the medical team to review the antibiotics to make sure that they make sense for this patient. So the patient is a 27-year-old female, comes in with a chief complaint. Her main thing is having some chest pain and feeling short of breath. And so this has been going over for a couple of weeks with that chest pain increasing. She's also having shortness of breath, and also showing signs of infection such as fever, chills, night sweats, and just also getting very tired easily with any activity. You note for this patient, looking at the past medical history, she had a previous case of endocarditis 3 years prior to this admission. There's also notes in the chart that said she also had an ER admission last week for the same complaints, but she left AMA against medical advice. Something we see documented a lot in our charts. We have notes about perhaps she had Hep C virus, but potentially spontaneously cleared, and multiple admissions for infection, but leaving AMA as it's said in the chart. We do a past surgical history for a fractured femur where she was hit by a car as a pedestrian. On the social history side, it's noted that she's currently houseless. She has 3 kids, with 2 of them currently in care through social services, unemployed on social assistance, and as part of looking at her drug use history. For alcohol, ETOH, there's no current use, but perhaps a history of previous use. Only smokes 5 cigarettes per day right now, but the big point of, that we're worried about is using, street drugs. So she endorses using fentanyl 5 points per day, which is a rough measure of use. So this person looks like sort of a moderate user. We can also see, again, those signs of infection are there. She does have a high temperature. She's tachycardic, and her respiratory rate is also going quite high. Lab tests are done to see what's happening with this patient, and we can see that her white count is up, so that again makes sense that she's got an infection, so her white count will rise. They also do an ECG just to make sure the heart is okay. They do a chest X-ray and they see multiple opacities. So bits of stuff in the lung that they're not sure what that is, on the right and left side. And they've also done a bunch of microbiology. So they've taken blood cultures with her having a high temperature to see if there's any bacteria growing in the blood. And they also do a sputum culture as she's having that shortness of breath. On a physical exam, you can see track marks on both her arms as well. So in this case, she's diagnosed, right now as a community-acquired pneumonia with bacteremia, and the source of that bacteremia is not yet known. So this is quite a sick patient. She's got what looks like an infection in her lungs, but also is septic with some kind of bacteria. And so our treatment plan for her becomes something where we're looking at antibiotics for community-acquired pneumonia, but also coverage for MRSA. And in so many cases, we need to go in and talk to the patient a bit more to understand a bit more of their history, or have some clarifying questions. And in this case, when we go in to see the patient, we see a young First Nations woman. She appears quite sick. And in trying to engage and talk with her, she's kind of just turned away from you, eyes tightly closed, and just not engaging. And I've been in this scenario, a number of times, wondering, how do I get more engaged with this patient to help them out? So some notes on terminology. I use the terms addiction and substance use disorder somewhat synonymously. So with sort of a rough overall picture of addiction, just referring to any behavior that's out of control in some way, and this people start exhibiting signs of problematic use, and those can be defined by the 4 C's, where somebody experiences a lot more craving, loss of control over how much they're using. They're experiencing compulsion, and experiencing harsh consequences and continuing to use. So in this case, with this young lady, she had a previous endocarditis from using, and so again, with her being so sick, she's continued to use. So clearly exhibiting signs of overuse. So, and when we get into more terminology like substance use disorder, these, as opposed to addiction is more behaviorally based, where substance use disorder, this is kind of a clinical diagnosis where we can use the Diagnostic and Statistical Manual, version 5, to see if patients meet those criteria that they would fulfill a substance use disorder. When we're talking about addiction and addiction recovery, recovery is really the process of improving your health in all the domains so that you're living a better, happier, healthier life. And there's a couple of things just to clarify about recovery. Recovery doesn't necessarily mean no drug use ever again, or taking an abstinence approach. Recovery is more taking those positive behaviors to move you in a better direction. So I like to think of sort of addiction and recovery on a bit of a spectrum, where we're really just looking at, in addiction recovery, we want to move the patient in the right direction, so that they're moving towards more recovery behaviors as opposed to sliding back into addiction. So, like I said, this isn't necessarily all just, you have to be abstinent. It can be things such as harm reduction steps, going to meetings, little pieces that get you kind of moving in the right direction. And just differentiating a couple of terms, we also hear a lot about medical detox as opposed to treatment. So just to clarify, medical detox is when somebody is getting those drugs out of their system. So, and this is a really important step in kind of getting into recovery, is making sure you're detoxed before entering any kind of treatment. and then going beyond detox into treatment. This is what we would, back in the day, everyone called it going to rehab, or, Amy Winehouse even sang about it. So, but, if we had an updated song on going to rehab, it would be going to substance use disorder treatment center as opposed to rehab. So, and within treatment, there's a number of a range of options available to the patient as well. So it's really making sure that treatment is individualistic for the patient and helps them with their particular needs. So, and again, treatment could a lot of the time this is consisting of getting into a rehabilitation program. Traditionally, they were 28 days. Now we see also day programs or longer term programs available for treatment. So looking at the concept of peer support, so this is receiving non-professional, non-clinical assistance from somebody who has lived experience. And peer support within the addictions world is not a new concept. I mean, if you look at Alcoholics Anonymous and Narcotics Anonymous, those are also considered peer-based programs that help people in their addiction. And there's been a growing body of evidence just to show that peer support is an important component of treatment and care overall. I think this is the last definition, but for two-eyed seeing, this talks about learning to see with all the strengths and wisdom of looking at the patient through the indigenous lens, but also taking the knowledge and wisdom of Western medicine and using the strength of both of those to give you your picture of what's happening with the patient. And an important concept here is that neither is considered superior. They're both given equal weight in looking at how do we help this patient. So for treatment gaps, for people like our patient, there's many. Just from this article is a few that I picked out. And the thing that I want to really highlight people to is also looking at those systematic processes we have in place in the hospital and in the healthcare system that really aren't working for patients. So we know, just discussing with patients, there's problems with access to care. There's generally just a lack of resources out there available to patients. When it comes to culturally appropriate care, taking a different process that way. A lot of time this isn't available. We are lucky in Regina that we do have First Nations Métis Health Services and some other supports that way. But yeah, there's a lot missing, and also just education for our clinicians on intergenerational trauma is a big point in caring for First Nations people. When it comes to medications for the treatment of addiction, I mean, we don't have great options. When it comes to opioids, we've got buprenorphine, naloxone or Suboxone, and also lots of experience with methadone. But beyond that, if I've had so many questions from patients who are having trouble with methamphetamine, and we don't have sort of a treatment per se for that, or similar to how we have opiate replacement therapy, we don't have methamphetamine replacement therapy. One other thing to talk about is also sort of the normalization of trauma, and I see this happening in our hospitals in Regina, where we see patients that are like our patient in the case, very sick and really needing help, but it's sort of there's sort of this normalization of that trauma. It's like, well, we see this all the time. She's been in here before, and sort of a normalization of something that this is really an unusual infection that is very serious, and this person needs help. Um, and just as a highlight, for I know in Regina, I'm sure this is the same around the province, but we don't have a lot of great connections to care for when patients are also in the hospital. And this is something that I find quite unfortunate when we have so many patients who, from an infectious disease side of things, a lot of patients who are stuck in the hospital for 4 to 6 weeks and don't get any of these mental health or addiction services provided to them when you do have, um, a perfect client for you there during that time to work with. Not addressed in this, we also have additional barriers to entering recovery that aren't addressed. So if we go back to the patient case and see what's happening with this young lady, one thing that really sticks out for me, working with stewardship and clinical appropriateness is we've uh, really been looking at healthcare in all these different facets and looking for inefficiencies where we're not doing well, where we need to improve. Um, and over my career, I've seen us as a healthcare system really failing these patients. So similar to how we'd look if somebody came in with myocardial infarction and how these patients are treated, how many were getting to the cath lab or to cabbage, getting on medical treatments. We have metrics for how we do with all these patients, but when it comes to our IVDU patients, our injection drug users, our people who inject drugs and are struggling with addiction. I think for a lot of these, if we're measuring our success, we have so many patients who are discharged or leave against a medical advice and are coming back into the system. So, and often it's always easier to blame the patient, and I think this is just generally done across the board. But I think we have to look more at the system and, okay, well, how is the system failing these patients? So if we're looking at them as a medical case, which they are, I think we're doing pretty poor if we have somebody who had endocarditis, didn't get any addiction supports around them, and ends up with endocarditis again. I think that's more on the system than on the patient. So now connecting to peers. Peers bring their knowledge of their lived experience um, to the bedside to meet with the patients. And so if I'm looking at a case like the case study we were looking at, not being able to connect with this patient, that's really where, I'm stuck there. And for me to be able to bring in a peer like Danita, who's able to sit down with that patient and say, look, I've been in your shoes. I was actually in that position a number of years ago. But now I've moved into recovery and I'm working to help people in the hospital. And I find patients just listen, their ears open up, their eyes open when I bring Danita in the room to talk to them, because she can connect on such a better level. So it's also providing some services that we don't really conventionally think of in healthcare. So for example, motivational interviewing is something that is an evidence-based strategy to help people with addictions, but nobody does it because it takes time. But if I have a peer who can go in and sit with the patient for even up to an hour, it's quite that's quite something, and it will have an impact for that patient. Lastly, we do have a increasing evidence base that peer work is helpful. Some of the difficulty with it, though, is there's so many different sort of variations in the definition of what constitutes a peer or what those peer activities would be in particular. And lastly, just a quick point, it's quite a cost-effective addition to healthcare. Again, if we're looking at bringing in a psychologist to do an hour of counseling, that would be a significant cost, but bringing in our peers who have great skills, this could be a cost-effective way to deliver that care. So in how our program started working with peers is it was initially where in stewardship and clinical appropriateness we had the antimicrobial stewardship program, and it was really clear that I had when I was working in that program, um, I was seeing a lot of patients with the infectious disease team who were in the hospital for, again, anywhere from 2 weeks, 4 weeks, 6 weeks or longer, getting treated for these infections, but they didn't have good supports in the hospital necessarily. And it's clear there's nothing really being done with the mental health component of their care or their addictive state, which is the whole reason why they're there. Um, I thought, well, let's try bringing in peers to meet with these patients and bridge some of those gaps and see what we can do. So the initial connection happened through Dr. Sue Skinner, one of our ID physicians, introducing me to Dr. Jolie Sasakamoose, who was putting together the Fawn program at that time, which was a peer program. That led to a quick meeting with Danita, where I told her a bit about these crazy ideas I had for, can we get somebody like you into the hospital? As Danita had been currently working as a peer with AIDS Saskatchewan. And from there, it was just linking up together with Danita to go see the patient as together as a team. So this slide kind of goes over a bit of my process. Like, what does this look like to go see patients and how to identify them? So as part of when I was working with the infectious disease service, uh, there was a program that was set up to look at all patients who were admitted with Staph aureus bacteremia. So in a lot of the time, these Staph aureus bacteremia were secondary to injection drug use of some kind. So um, it was clear a lot of these patients were injection drug users. And so how I would line that up is I would see the patients in for Staph aureus bacteremia or a serious infection. Uh, from there, I could look a little bit into um, their history, uh, and what I'd see a lot of time is patients would be described as, they're in hospital for a number of weeks, but they're not a home IV candidate. So they can't continue their antibiotics outside of the hospital because there's concerns about them continuing to use. So I would go in and talk to the patient and, just start a bit of a brief interview, telling them my role and what I was looking to do. And also just introducing the concept of, you know, there's certain things I can look at clinically with your care, but I also want to make sure that you're getting support while you're in the hospital. And I think this is an area that we fail with a lot is getting people connected for their mental health and addictions piece and steering you towards recovery. So I'd say to the patient, and this is up to you, but I do work with a First Nations lady who's a peer mentor and does have life experience in this area. And I've brought her in to meet other patients similar to yourself. Um, and part of it is just providing that support while you're here in the hospital. And is this something you're interested in? And 9 times out of 10, I had patients saying, yes, I'm definitely interested in that. And so we had set up a meeting where on the next visit, I would come and Danita and I would go together for a first visit with that patient. I could introduce them. We could, talk a little bit. And Danita could tell them a little bit more about what she does, what sort of help she could provide. And this could be anything from, I'll sit in your room and talk. We'll have a coffee and just have a talk about life. I can share my own life story. Danita also, a lot of these people are in the hospital for so long, they're quite bored. So she would set them up with either reading material, um, coloring, or even beading kits for doing beading and different activities like that. going beyond that, where Danita was really beneficial on our team is that she could also help steer those patients towards harm reduction services if they were moving that direction, or we could talk to them more about opiate agonist therapy, methadone, Suboxone. She could also steer them towards recovery meetings, which she was doing in the community. So extending that support beyond the hospital for when the patient gets out. And also just creating that network around a good social support network for the patient. And so this is kind of how that cycle would work. We would also have patients being phoned from, we did work with a couple of different pharmacies in the community. So we would hear from them that, oh, we've had a patient who's ended up in the hospital. Can you go, keep an eye on them? And so this is where Danita and I could again meet up with that patient just to provide them additional supports for while they're in the hospital. So two-eyed seeing, I think I'll have to speed up here a little bit, but just again, two-eyed seeing is combining those two processes of looking through the Western lens and the Indigenous lens. And some important points to make here too is I think we would always see Western medicine as, oh, well, is this better? We are evidence-based. We've got all this scientific process. And yes, that's great, and it provides us with a good basis for evidence. But looking at things from an Indigenous perspective, there's this very long oral history of evidence being essentially passed down. So there is, you can look at both sides as having a real evidence base. But for me and Danita working together, I would take on the much more clinical lens in working together with the clinical team, and Danita could really work together with the patient. Some downsides to this work is it is quite heavy. Danita and I have had patients who have passed on, and it's very difficult. We also, I think we need more people, just the capacity for the number of patients we're seeing in the hospital with these problems. We need more supports. And so some of that could come through funding as well, just to recognize the importance of these, the peers and getting them hired into the system. So for addressing some of the barriers we were seeing with addiction, so the Wellness Wheel team expanded on the peer program, and this is where Dr. Kara Spence, Michelle Dornan, and Tricia Campbell came in to develop a training and certification system. Well, first actually connecting the network for people who are out there, and then working on a system of recruitment training and deployment to get peers out into the community. So one of the things to say here first for connecting the network, there are peer programs throughout the province kind of doing different things. So part of the idea was bringing these different groups together to help us support each other and create a bit of a network that way. For the network, we had people right from one of our main networks was Attack-a-Coop First Nation, but we also have peer mentors from different cities, Prince Albert, Saskatoon, and Regina, and different reserve areas from around those cities. So we have peers from all over the province. And part of again bringing us all together, we embarked this last summer on a number of land-based learnings, something also called adventure therapy. So we found this pretty, a great opportunity to recruit peers to come on this training. It allows us to really spend a lot of time together and get to know each other. And it was quite adventurous. We actually even asked for, on our second trip, I think we asked, can we have like sort of an adventure light version of this? Because, 2 hours of canoeing, it's too much for me. I'm more into the fun stuff. So, and here we have a couple pictures from, this was up in Attack-a-Coop First Nation at Sequan's house. We had our big main tent set up there, and for this it was for a horse dance ceremony up in Coop. So we're able to bring a group of peers and even a family up there as well. And one other note, just to say, for some of our peers who were on these trips as well, we did have people who were currently getting into recovery or different stages of recovery. We also had people who were on opiate agonist therapy, methadone and Suboxone on some of these trips. And, this, getting connected to culture was a big part of their treatment. So, and for certification, we also had a large conference this past fall where we brought together all our peers from across the province and had a number of days of training, including ceremony with an elder. And this was at Dakota Dunes. Great time with those people out there. So lastly, I'm just going to talk really quickly about the deployment of peers. So this is going to be next steps for us. There's been a lot of work with the wellness wheel, getting peers and still continuing to recruit and train our peers. But we're trying to look at, okay, well, where are those next priority areas now that we have trained peers to get them into the healthcare system? Based on the work that Danita and I have done, I've been really advocating for, I need more peers in the hospital. I've got so many patients who are really suffering and they need that support. So that's the place where I'd like to see them start. But we also have, different services around Regina, like at All Nations Hope or Queen City Wellness Pharmacy, where they're also doing a lot of work to connect with peers and give them a safe space to be. A little more difficult is also we're looking at doing a retrospective analysis of the work that Danita and I have done. So this is going to be Tricia Campbell looking at it as a master's project, but we're also looking at doing additional research for continuing the education of these of the peers in providing motivational interviewing training, and looking at continuing our sports. So this next year, I think we're going to be doing some more adventure therapy and continuing the process of recruitment training, certification, and getting our peers out into the community to help people. So for me, it's been this has been the best part of my job, is working with Danita and together to help patients, and very valuable. I find the work she does is really good, and I just wish I could hire more Danitas out there. So with that, I'd just like to say thank you to everyone for listening to the presentation. Danita is also on the presentation here, so I didn't want to put her totally on the spot, but she would be available for questions as well. But yeah, thank you everyone for listening, and let me know if you have any questions.